Thank you, Chairman. I'd like to ask the panel's help with a couple of things as we go forward. We've talked about prescription drug monitoring programs, the PDMPs. The problem that has long existed with them has been a lack of integration between states, a mishmash of different reporting requirements, and a poor or fraught relationship with law enforcement. We got some additional money for grants to support improvements in the PDMPs. DOJ is going to operate that, but I do think that they will be looking for interagency support on all of that, and I hope that you will support PDMP grants that do a better job of crossing state lines. It is ridiculous for somebody to be able to go from, Woonsocket to Attleboro and have it not picked up across the Rhode Island-Massachusetts border. And we just went through a terrific fight at the state legislative level between the doctors and law enforcement about law enforcement access to PDMP records. In part, that was a fight because there had been such weak policy work done at the federal level to sort out what makes sense for law enforcement to have and what maybe doesn't make sense for law enforcement to have. So I hope that those two areas will be a focus of yours if you're consulted and as you deal with PDMPs. The second thing has to do with the next $500 million in Cures Act money. I hope that all of your agencies will vigorously support making sure that that gets into the December funding bill. We shouldn't have to wait around for that. I hope also that you will support efforts here to, in the terms and conditions for the grants that the $500 million will flow out into, try to encourage alignment with the goals of CARA. We sent a big bipartisan signal with that. It doesn't have to be a hard stop, but it ought to be part of the consideration by which grant applications are measured. And another one would be a higher focus on the extent to which particular states have been impacted by the problem. And we're going to try to make sure that that gets into the funding measure. But I really think that those are important considerations, and I hope we'll have your support on those as we lobby for them towards the December spending. The last thing, and this will be more in the nature of a question, you can have all kinds of medically assisted treatment, you can have all kinds of experts who are properly trained, but if people don't have access to the treatment, then it really doesn't matter. You've got to catch them. The two places where I think we have the greatest frustration are emergency rooms. We just did a good program in Rhode Island, so they actually do connect, and you don't leave an emergency room if you come in for an overdose without a treatment coach, without a recovery coach. And the second is people who volunteer, who come in and say, I'm desperate, I finally need treatment. You can't tell somebody like that, sure, come back Tuesday 2 weeks from now and we'll be able to see you. You might as well tell them to go, well, I won't use the term. So I hope that we can think of ways to try to catch people when they're most amenable, either because they've just had a horrible experience with an overdose and are maybe had their lives saved in the ER. Part of that is the recovery coach. Part of that is also breaking through HIPAA. You know, it is bonkers that a mom and a dad may not know that a 22-year-old or 24-year-old child has been in and out of the emergency room for overdose. That is not what HIPAA was intended to do. And so if you could give us some advice on ways that we should be fixing that. I know my time is running a bit short, so feel free to, and it's a long thing, so feel free to make that a response for the record. We need to fix this. We cannot have people turned away at their time of openness to this or sent back out into the street after they've turned up in an ER. Dr. McCants-Katz, you've got Rhode Island privilege to answer.
And I'm going to talk about Rhode Island, Senator. So we do have a program in Rhode Island that places recovery coaches with people who've overdosed. But here's the other thing that we're doing in Rhode Island and that we will start talking to the rest of the states about. So here's what we've learned, and I know this because I have worked in Rhode Island Hospital ED with some of these folks. And what we see is that when they come in and their overdose is reversed, one of the things we need to be aware of is that that's often not the time they're interested in treatment because they're going through withdrawal and they really want to get out of the ED. So what we are doing in Rhode Island is getting people asking them to sign a consent form so that our recovery coaches can contact them a few days later. Yeah. And we think that that is going to make a big difference in getting people to the care they need.
Yeah. No, so, I'm familiar with that. I just want to see it more of a national model.
Well, and that's where SAMHSA comes in, and we will be disseminating those kinds of models, absolutely.
Thanks.